Hey everybody, welcome to Drugs Affecting the Cardiovascular and Renal System. I hope that this presentation helps clarify some conditions related to drugs. This can be a really tough section because there are a lot of drugs, and how do I pick which one do I choose? Now, there is a method to the madness as to why we choose certain drugs over others, and we're going to make this a little clearer to you in the upcoming slides. So let's move on. All right, our first one is angiotensin converting enzyme inhibitors, or ACE1 inhibitors, and we see these a lot used in practice. Um, And how do they work? What's the mechanism of action? That's what that means. Well, how does it work? Well, it promotes salt excretion by augmenting renal blood flow and reducing the production of aldosterone and ADH. What's ADH? Do you remember? Look it up. You should know what it means. So remember when I went back and talked about pathophysiology, everything in medicine is connected back to patho, right? And that's how drugs work as well. They do something where they interrupt a pathway, or they increase the production of a chemical in the body. But somehow or another, scientists have identified these medications that cause these things to happen. Thank goodness. ACE inhibitors also prevent an enzyme in the body from making angiotensin 2. And that's very important because angiotensin 2 has the ability to narrow arteries. So we don't want that to happen. Okay? So Um, now think about what we said in the mechanism of action. It promotes salt excretion. So think about in the body when you have salt and you have water, right? So what happens? Water follows salt, right? So if that's going to happen, what is this patient at risk of developing? Think about it. Hypovolemia, and what happens if someone becomes hypovolemic. That means that they have low blood pressure. So those are things that are risks, and any risks, we're going to have a conversation with our patient and tell them that if any time you feel dizzy or lightheaded, I want you to let us know right away. They may not need to go off the medication. Maybe it just needs the dose needs to be adjusted. Okay. Other side effects that you'll see are dry cough. Dry cough is one of those things you're going to end up changing the patient, because the dry cough in people on an ACE, it drives them nuts. So let's hope they don't get the dry cough. We're going to watch their potassium levels, because with these fluid excretions, you're going to see potassium levels may drop. So we're going to watch our potassium levels. Um, who are we not going to give these drugs to? Well, we're never going to give it to somebody that's pregnant, number one. We don't use this drug in someone who has aortic valve stenosis or is chronically hypovolemic. Um, and so that's we're not gonna to use it in that population. All right. Drug interactions. We want to avoid NSAIDs, antacids, lithium, and diuretics when we are on this, because they can interact. They can interact and cause different things to happen in the process. Remember, we don't want to ingest something in the body that is going to interrupt what this drug does. So we want to avoid the use of those, and that's going to go in your teaching, right? You want to avoid nonsteroidal anti-inflammatories, antacids, lithium, and diuretics. So, of course, the patient would know that they were on lithium, right? Um, we use this drug in heart failure patients. It has great benefits. It's also the first line uh, drug for those who have kidney disease, and it can delay nephropathy or worsening condition in the kidney and cardiovascular events. So it is a great drug. Names you'll see: enalapril, lisinopril, zestoril, benzapril. It's those aprils. Now, how do we decide who's going to go on a blood pressure medicine? Well, I was reading an article and I really liked how it stated it. Now, different clinics are a little different. Like, well, my doctor knows I'm a nurse practitioner, so the last few times I've gone in, my blood pressure's been slightly elevated. And he said to me, April, I think it's time that we talk about you're going on a blood pressure medicine. And I said, okay. And we talked about it. And that's how we decided that I was going to go on a blood pressure medicine. Very low dose, and it worked immediately. So, good decision because we want to address hypertension timely, right? But this article said that if someone has, and remember, we never diagnose hypertension in isolated visit. They have to come back a couple of times and have repeated elevated blood pressures. I always tell my patients, I want you to keep a log at home because sometimes their blood pressure is just normally elevated in the office. For example, this article said that if you would treat the patient if they consistently had an office blood pressure of 140 over 90. So they let it go higher because the patient's in the office and you may have, they're nervous, white coat, all of that stuff. Or they consistently have a blood pressure of 135 over 85 outside of the office. Patients we're going to treat a little bit sooner, those with diabetes and cardiovascular disease, and those over the age of 65, a blood pressure of 130 over 80. Now, again, remember, we never treat a patient with one elevated blood pressure. We want to have a series of them so that we can identify that the patient truly has elevated blood pressure. Okay? All right, so I hope that clears up a little bit in the ACE inhibitors. All right, let's talk about angiotensin 2 receptor blockers, and our ARBs, as they are known. Now, we can go into real depth of the mechanism of action at the pathophysiologic level, okay? But we don't need to go there, right? Our body has angiotensin in it, all right, naturally, okay? And if we have too much, that it increases the fluids in our body, which causes our blood pressure to rise and our blood vessels become narrow. So we end up with high blood pressure, right? And so the angiotensin that we have in our body needs a receptor, as most things do in the body. It has a receptor that comes up and connects to it and lets it do its thing, right? So what does an ARB do? An ARB, you see where it says receptor blocker? An ARB blocks the receptor from attaching to the angiotensin, which is normally in our body. And if it's blocked, what's going to happen? It's not going to be able to work. It's not going to allow increased fluids, blood vessels to narrow, and blood pressure to rise. So it blocks that receptor, and in doing so allows normal function of the blood vessels. They stay open and your blood pressure goes down. So very simple explanation, but we don't need to go into that pathophysiologic stuff. You did that already. And it can cause dizziness, lightheadedness, swelling, and it can cause a cough. You want to avoid NSAIDs, and you have to check potassium levels on these patients. You don't want them taking potassium supplements. They don't need to do that. And some common names for these drugs are losartan, valsartan, and we're going to follow the blood pressure parameters when we prescribe these. And when we are prescribing blood pressure medications, what are we looking for? How do we choose a blood pressure medicine? Well, we want to follow what our professional organizations say to do. All right, and we want to follow the JNC7. It's been JNC7 forever. They must create an 8 sometime. Oh, here's an 8. 8 guidelines. They must have come up with it. Oh, that's good. So these guidelines really help identify what medications we should introduce first and second. So I would definitely advise you to look at these guidelines, and if you're going to be working in this population, or especially, you know what I was thinking, for clinical, if you're going to be doing primary care, I would make a little graph of the different types of blood pressure medication and when you're going to use this or that. In fact, I think I'm going to look at this, the GNC8, because I haven't looked at it in a very long time. And then I'll get back to you on that. So education, we're going to teach our patients that this medication, especially when they take their first dose or two, might make them a little dizzy, lightheaded. They can actually faint. If they develop dry cough or swelling, notify us, please. And we will occasionally monitor their potassium levels to make sure that they are not experiencing elevated potassium levels. Okay, easy peasy. Okay. I found a great reference for you that I put in here. So this is something that this is the JNC8, and it's not new. My bubble was burst when I looked at the date. But these are the standards, these are the guidelines. This is going to help you choose what kind of a blood pressure medication you're going to choose on your patient. And your preceptor may ask you that question. So it's good to have this handy. And I hope that you have put together a notebook, as I advised you to do early on, so that you know the treatment modalities for common illnesses. It can be a clipboard, it can be a notebook, whatever works best for you. I used a clipboard, but I had commonly seen conditions with the treatment plan in there that I used in clinical. So this is something you definitely would have in there. I'm not going to go over it, but these are the standards, and this is what you're going to use in practice. Okay, let's talk about calcium channel blockers. And let's see if I can get through the pronunciation of this. Dihydropyridine versus non-dihydropyridine. Okay, what's the difference? Well, there are two types of calcium channel blockers. The dihydropyridine are nifedipine and amlodipine, those types of drugs. The non-dihydropyridine. Diazepam, and verapamil. Those are examples of those drugs. All right, let's talk about the mechanism of action. It's pretty simple, really. It stops calcium from entering the cells of the heart and the artery. And again, it goes back. There is a mechanism of action that takes place that prevents this from happening. But the calcium causes the heart and the arteries to squeeze stronger, and by blocking it, it allows the vessels to relax and open. So think about it. Now we're relaxing the heart, right? What patients should not be using this if we're relaxing the heart? Heart failure patients, absolutely a big no-no because their heart's already too relaxed. So we don't want to use it in those patients. But, and think about it, muscle contraction and calcium, right, in other parts of your body, calcium is very important in the contraction of the muscle. And the heart is a muscle. So that calcium channel blockers and blocking calcium from entering that cell is going to relax it. Now, who shouldn't use it? People who have sick sinus syndrome, unless they have a pacemaker in place, severe hypotension, and acute MI, pulmonary congestion, heart failure, like we said, liver disease. And drug interactions, you need to, anytime, I use Hippocrates. It's the app I have on my phone, but there is a good one. It's I think it's Medscape. It's free and you can download it. I don't know why I don't just use that one, because I used to use it, and it was a physician friend of mine is actually who showed it to me. But keep those things and it will show you, when you're going to prescribe a drug, any drug interactions. Digoxin is not a good thing because it can increase the levels of digoxin in the body to toxic levels. And you need to be cautious when using statins with these drugs as well. Education, you're going to talk to the patient and tell them they may experience some fatigue. They may experience swelling in their feet and legs, and they can experience bradycardia too. If any of those things take place, they need to notify you because you are now their healthcare provider, right? Also, we want to advise the patient not to drink huge amounts of grapefruit juice. Now, that's what my references said, huge amounts of grapefruit juice. So I don't know anybody who drinks huge amounts of grapefruit juice, but you never know. In the event your patient does, they shouldn't do that if they're going to be on a calcium channel blocker. All right, on to the next one. All right, next step, digoxin. So those of you who've worked in ICU have used this drug for sure a lot. And so let's talk about the complex mechanism, okay? So it inhibits sodium potassium and adenosine triphosphatase or ATASE. It has a predominantly parasympathomimetic action on the atrial myocardium, slowing conduction, prolonging AV node refractory period, increases intracellular sodium, and drives calcium into the heart, increasing the contractility of the cardiac system or cardiac output, and increases cardiac output, decreases ventricular filling, and decreases the heart rate. Okay, so that's the simple form of discussing it. So that increase in intracellular sodium drives calcium into the heart and increases cardiac output and decreases ventricular filling. And in turn, it lowers the heart rate. So that's the mechanism of action of digoxin. And it's got a lot of things that you have to look at. If your patient is experiencing heart failure or AFib, it's a big no. Patients on digoxin can suffer anaphylaxis. So that's something that you have to look for. Other contraindications are cardiomyopathy, Wolff-Parkinson syndrome, heart block, pericarditis, myocarditis, recent MI. And it's got a lot of drug interactions: erythromycin, amiodarone, calcium channel blockers, and acid. And this one I didn't understand really. Large amounts of oatmeal and milk. Again, we've got large amounts. Um, you should in teaching, you're going to routinely assess the pulse prior to administration and assess for toxicity. So dig toxicity, the patient's going to be confused, may have vision changes, diarrhea, vomiting, all of that good stuff. And then that is going to need immediate intervention. Okay, so that's the basics on digoxin. We use it mainly because we want the heart to beat stronger. Okay, so let's see. Oh, we use it in heart failure. Did I say that? Or did I say we don't use it in heart failure? This we do. We use this in heart failure, and we use this in AFib. Sorry if I messed that up. All right, let's talk about procainamide, which is something I very likely believe you will never use in your career, but it is an important drug. If you are ACLS certified, I'm sure that you know about it. Procainamide is used, it's an injection for life-threatening irregularities in the heart rate. So it's used to treat life-threatening ventricular arrhythmias. And how does it work? It's considered a class 1A antiarrhythmic, and it binds to the fast sodium channel, inhibiting recovery after repolarization, prolonging the action potential, and reducing the speed impulse control. So I think that's all you need to know about that one. I don't think we need to go in any more depth. Dr. Pantano? Whoop. All right, let's talk about amiodarone. This is an antiarrhythmic, type 3 antiarrhythmic, and it is only used in life-threatening situations. However, it is used in many off-label situations, but we're only going to consider the life-threatening situation. And the mechanism of action is that it blocks potassium channels. It can also block sodium, calcium, and beta and alpha adrenergic receptors. It is names are Nextrone and Pacerone. So you can see it ends in the erone family. And here's a little bit longer explanation of the mechanism of action. Non-competitive antagonist of alpha and beta adrenergic receptors. It is a type 3 antiarrhythmic causing prolongation of the action potential of the atrial and ventricular tissue. Now, who shouldn't take this? Patients with lung and liver disease, worsening heart issues. It can actually cause lung problems, liver disease, and worsening of heart conditions. You want to, side effects could be nausea, vomiting, shakiness, constipation. It can interfere with the mechanism of Plavix, statins, warfarin rather, and you want to avoid quinolones and macrolide, antibiotics, and grapefruit. no grapefruit at all on amiodarone. So that's the story on that one. All right, let's talk about nitrates. So this is your nitroglycerin that we're so commonly um, we know it commonly by nitroglycerin. And what does it do? It decreases the myocardial oxygen demand by producing systemic vasodilation more than coronary vasodilation. And it does this by the activation of the intracellular NO receptor enzyme, soluble glycylase, and that goes on and on. But essentially, it decreases oxygen demand. So it decreases left ventricular filling pressure and systemic vascular resistance, and modestly improves cardiac output. Modestly. So we use this in patients who have angina, NSTEMI, portal hypertension. They used to use it in asthma. They don't do it anymore. Patients who are using nitroglycerin should not use Viagra under any circumstances. Some of the side effects can be headache, dizziness, or they can also build up a tolerance to it. So then they need to go off of it for a while so that they can then get the relief from it. If a patient experiences nitrate toxicity by taking too much, methylene blue is the antidote, which was really surprising to me because we used to use that in the olden days when in surgery to check to make sure that the bladder hadn't been perfed. But I guess it can have other mechanisms of action as well. So that is nitrates or nitroglycerin in a nutshell. All right, we're going to talk about statins. It seems like everybody is on a statin these days, so it's very important to learn about the mechanism of action and all of those things where statins are concerned. And it's pretty complicated, but it actually, if you break it down to understand it a little more easily, what statins do is it binds reversibly to an enzyme, okay? So it is an enzyme blocker. And it blocks an enzyme that is related in cholesterol biosynthesis, okay? So I'm going to talk about a few things here. I don't want to go too in depth into the pathophysiology of statins. But let's see. Let's look at the AHA-ACC guidelines for LDL level reductions. Okay, now there are 3 different kinds of statins. There's a high intensity statin, moderate intensity statin, and a low intensity statin. You need to know what those are. Okay. So patients with severe primary hypercholesteremia, which is an LDL of greater than 190, who have a high risk of atherosclerotic cardiovascular disease, should be started on a high-intensity statin. For young adults between the age of 20 to 39, consider statin therapy only in high-risk patients, and that is if they have a family history of young cardiovascular disease or a very high LDL greater than 160. Patients between 40 to 75 with diabetes are at an intermediate or high risk. and a moderate intensity statin is recommended. So if you've got diabetes, you're going on a statin. Patients between 40 and 75 of age with diabetes specific factors like so they've got albuminuria, retinopathy, neuropathy. They're going on a high intensity statin. Um, Consider treatment with a high intensity statin for patients between 40 to 75 with an ASCVD of greater than 20%. That's high risk. So, what is ASCVD? This is a calculation score that is done that determines your risk of developing cardiovascular disease over the next 10 years. And if it is a certain level, it puts you at high risk or low risk of having a cardiovascular event. So consider treatment with a moderate intensity statin for patients between 40 to 75 years with ASCVD of 5% over 10 years. So if the in young adults 20 to 39, consider a statin only in patients with a family history and a very high LDL of 160. So we went through all of those things. I said that again. All right. So who are we going to worry about? Statins are generally well tolerated, but some patients, it's actually less than 1%, develop rhabdomyolysis, which is the leg muscle problems. And in rare cases, patients can develop diabetes as well. But it's quite low. Statin-associated cognitive dysfunction is also very low. Let's see. Liver function tests should be done. So this is what you're going to be doing before therapy is initiated. And generally, they repeat it 3 to 6 months after the initiation of treatment. Statins are well-established drugs. They can be toxic, but there is no antidote to reverse the effects that can be caused by statins. And let's see, I want to make sure I got everything on here. They can cause headaches, dizziness, constipation, diarrhea, gas, muscle pain, decreased platelets. I think that is all I have here on statins. Let me see. Let me make sure. I want to look through this. Okay. So, know the low, moderate, and high intensity statins and who should get them. I went through the list, right? So, and low statin, it can be the same name, okay, but a different dose. So a low intensity statin is simvastatin, or what? Let me see. No, I don't have it on there. Well, let's look at this one. A moderate intensity statin can be 10 to 20 milligrams of atorvastatin, and a high intensity statin can be 40 to 80 milligrams of atorvastatin. So it doesn't necessarily have to be a different medicine. It's a higher dose, if that makes sense. And remember, it is an enzyme blocker. It blocks the enzyme involved in cholesterol biosynthesis. All right, we're going to talk about fibrates here now. Some of the names of them is fenofibrate. That's the one I see most often in clinic. I'll get this one totally, I will butcher this one. Gemcitabine or Lopid. I've never seen that one in practice. but it decreases the synthesis of bile acid by downregulation of cholesterol 7 alpha hydroxylase. Um, so it stimulates the cellular fatty acid uptake of VLDL production. So let's take that and turn it into something you can understand. Okay. Fibrates. What makes it so wonderful? It targets triglycerides in the bloodstream, and it decreases the liver's release of triglycerides, increases the production of lipoprotein, which actually breaks down triglycerides in the bloodstream. So it's a twofer. It targets triglycerides in the bloodstream, decreases the liver's release of triglycerides, and increases the production of a lipoprotein, lipase, which breaks down triglycerides in the bloodstream. So that's great. You don't want to, you want to be on a low-fat diet and don't drink alcohol when you're on this. Patients who should not be on this are those who have liver, gallbladder, or kidney disease. And side effects can be abdominal pain, rash, muscle pain, pretty much neck pain. Um, but fibrates, those are for people with those they're on a statin, but their triglycerides are out of control. So they're trying to get their triglycerides back in order. Okay, so let's talk about bile acid sequestrants and their mechanism of action. These block bile acid in the stomach from being absorbed in your blood, and your liver needs the cholesterol from your blood to make more bile acid. And so this ultimately reduces your cholesterol level. So it is like a cycle that occurs. Now, since the bile acid sequestrants are not absorbed in the GI tract, they have limited systemic side effects, but some of the most common are GI, including constipation, stomach pain, bloating, vomiting, heartburn, loss of appetite, indigestion, and upset stomach. These bile acid sequestrants are often used in statin intolerant patients, and they can be used in combination with niacin and a cholesterol absorption inhibitor, STMEB. I said that totally wrong. And they can actually lower the LDL between 15 to 30% in full doses. Okay. And this is typically a tablet or granules for oral suspension. And for pregnant women, this is a pregnancy category C, so I would avoid that. It's okay in breastfeeding. There's no information on hepatic impairment, and um, you need to be cautious for people who have renal impairment. Be careful for peptic ulcer disease and hemorrhoids. Using it chronically correlates with bleeding problems in high doses, but that can be preventable by using oral vitamin K. It can induce malabsorption of fat-soluble vitamins, so the patient should avoid bile acid sequestrants if they have those deficiencies. They can also decrease the absorption of many drugs. So you need to take a look at those. If they have a narrow therapeutic index like thyroxine, digoxin, warfarin, hydrochlorothiazide, they should be taken 1 hour before or 4 hours after the bile acid sequestrants have been taken. This is contraindicated in patients with biliary obstruction, inappropriate for use in patients with serum triglycerides greater than 300. That's just too high. The monitoring of bile acid sequestrance therapy is via a reduction in LDL concentrations. So that's how you are going to monitor whether or not it's working. Monitor for constipation, monitor INRs for those on warfarin, and with concomitant use with cholesyvalum hydrochloride, it can increase the exposure of metformin extended release formulation. I don't know about that. So I think that covers bile acid sequestrants pretty thoroughly. All right, next on the list, niacin. So how does niacin work? It increases the vascular endothelial cell redox state, resulting in the inhibition of oxidative stress and vascular inflammatory genes. What does that have to do anything? Well, ultimately, it inhibits a hormone-sensitive lipase in adipose tissue, which reduces the breakdown of triglycerides to free fatty acids and transport of free fatty acids. So that in itself tells us a little bit about niacin. So it's been used. Nicotinic acid is what you may have heard it called by. It's been used a long time for the treatment of lipid disorders and in cardiovascular disease. You can get some good effects from it. And I have started, I think that it went out of favor for a while, and it's starting to come back because I've been seeing patients with it more often. Let me see. Indication, okay. Who should not be taking this? Patients with active peptic ulcer disease, patients with active liver disease, or persistent elevations in hepatic transaminase, patients with hypersensitivity to niacin or any component. You cannot be on anticoagulant therapy when you're on this. It can increase the risk of bleeding. People with a history of liver disease, kidney disease, stomach ulcers should not be taking it. It can cause dizziness or make you feel faint. And I think that covers. Well, let's see. Let me look at one more. Yeah, this is usually used with another medication like a statin. It can make you feel flushed. That's what I forgot. I wanted to tell you. That's true. It can make you really have flushing of the face. Yeah, I think that's the main thing I didn't want to forget, the flushing. Okay, great. Okay, last but not least, diuretics. Diuretics are drugs that increase the flow of urine. They are used to treat edema, hypertension, and heart failure. There are 5 classes of diuretics: thiazide diuretics, loop diuretics, potassium-sparing diuretics, osmotic diuretics, and carbonic anhydrase inhibitors. But we will typically just see thiazide, loop, and potassium-sparing in our practice. All right, they act by diminishing sodium reabsorption at different sites in the nephron, thereby increasing urinary sodium and water losses. A second class of diuretics can inhibit water reabsorption by blocking vasopressin receptors. So you have to look at each each diuretic and what the mechanism of it is. Let's look at furosemide, which is a potent loop diuretic. This works to increase the excretion of sodium and water by the kidneys by inhibiting their reabsorption from the proximal and distal tubules, as well as the loop of Henle. It works directly, acts on the cells of the nephron, and indirectly modifies the content of the renal filtrate. Okay, we talked about thiazide diuretics. Mechanism of action. Okay, potassium-sparing diuretics act to prevent sodium reabsorption in the collecting tubule by either binding ENACs or by inhibiting aldosterone receptors, preventing excessive excretion of potassium in the urine and decreased retention of water, preventing hypokalemia. Okay, so that's that one. Diuretics. Okay. Oh, thiazide diuretics. Inhibit the reabsorption of luminal sodium in the distal convoluted tubule of the nephron. Let's see what this is. Okay, and diuretics are among the most frequently prescribed meds out there, which is surprising to me, right? They promote the excretion of water and electrolytes by the kidneys, increasing the rate of urine flow. Buildup of fluid in body tissues as a result of an inability of the kidneys to release sodium and the water that is excreted along with it. Remember, salt follows water. So if sodium is being hung on by the kidney, the fluid isn't going to leave. Once that sodium's released, bam, the fluid's going to follow it. So diuretics are used for edema, heart failure, hypertension, and there's a lot of reasons that people use them. Loop diuretic furosemide, we talked about that one. It can lead to, that's given for edema, heart failure, oliguria, hypertension. And potassium sparing, it reduces the risk of hypokalemia and hypertension. Is that it? Oh, no. So you really have to watch to ensure that these patients, if they're not on a potassium sparing, that their potassium level stays good. I can remember back in the day when I was in nursing school, we had to check our patients' potassium levels every morning before we passed meds because everybody was on Lasix to ensure that they had an adequate potassium level. So we need to make sure that our patients have an adequate potassium level if they're on, unless they're on a potassium sparing. And you say, okay, why isn't everybody just on a potassium sparing? Because it doesn't work that way. They don't work that great. Let's see what some of the side effects are. Peeing more than usual, dizziness, fatigue, headache. They can develop gout, and we'll talk about that later on. Difficulty getting an erection, low potassium unless you're on the potassium sparing, and muscle cramps. All right. And, oh. Some medications that might interact with a diabetic, or with the diuretic rather, cyclosporine or Restasis, antidepressants like Prozac or Effexor, lithium, digoxin, and some other high blood pressure drugs. So those have to be reviewed to ensure that it's safe to use. All right. So I think that that covers the key points of diuretics. If you have any questions, give me a holler. Let's see how this presentation goes and let me know. Thank you.